I do record our lessons as well for those who are not able to join for a day or two, so that you can get it to watch. So I do record them. So so I have the cardiovascular system. The cardiovascular system, I had explained it, I said it already, but we have the blue ones carrying deoxygenated blood, everything that is blue. I don't know if you remember all of that. One thing about the NCLEX I have also seen is that students downplay it. This is my focus for the review. I have another document to send you how I do the setup for the review. I was supposed to explain that to you, but your group is like you are joining these people that are already somewhere. So I actually haven't officially started with your group with what we do. So I have a setup of what I discuss every week. So when I finish discussing that topic, I send you the document to read. Now, this is how my review is set up. I believe in content because when I first came in and I was trying to pass these exams, one thing I got to know, or one thing I was told, was that you have to know how to answer questions. But one thing I did was I answered a bunch of questions. I tell you, I answered thousands and dozens of questions in books. Every day, all I did was trying to eliminate answers and get correct answers. So I did it and I went back, I went in, I failed. Then I came back and I had to sit down. I had somebody tell me the bitter truth. The bitter truth was for me to take off and do a proper studying. Because one word I always remember was that the people that said the questions are not stupid. And that is true. So that I'm also telling you today that if you have taken this exam before, or if you have never taken the exam before, the people that said the questions are not stupid. They are people that have been on the floors, they have worked as nurses, and they are those who said the questions. And also to let you know, they get the questions from nurses who have passed the exams in the last 6 months. So when you take the exams and you pass it, and you go to the floor, within 6 months, they send you a letter. They send you a letter and they ask you to evaluate, to write to them what you see. You write to them what you think about your new practice as a nurse. You think about your assignment, your role on the floor. So if you are thinking about your role on the floor, and what you are doing on the floor, then what do you think? Do you see patients with this problem? And does patients ask you questions like this? So if patients ask you questions like that, what do you answer? So the people respond. So when nurses all over the country send in their response, they use that to set these questions back to those who are still trying to come in. So because they get the questions direct from what is happening on the floor, a patient walk in and asks you, I have this pain in my head. Is that where my temporal lobe is? So that's what they base on to ask you questions. But also, mind you, I had mentioned to you that they are not stupid. They want you to know the contents. Most nurses, especially those trained in America, that's one thing that makes them having challenges to pass it. They like to answer questions because we get used to it. So when you finish school and all you do is you go for UWorld and you are answering and reading rationales. Remember, the rationale still doesn't give you everything inside the book. So besides the rationale you are reading, you are just reading the rationale for only that question. But this is a whole topic they are talking about. The question is talking about heart failure. So you're reading rationale about congestive heart failure, and it has so many other structures, so many other symptoms to monitor. Probably the only option they mentioned in that symptom was shortness of breath. That's what the rationale is going to focus on. It doesn't give you a clear background. So one thing I do believe is for you to have this book knowledge. You need to know what the anatomy and physiology of a human being is before you can go answering and eliminating answers. So if you know everything about the cardiovascular system and they go and mention mitral valve replacement, you can already get this picture and you know that this is a valve. You have a valve here, you have another valve here. So we have the mitral valve here. They tell you they replace it. In your mind, on the exam, you can already picture. So if they replace the mitral valve, and the mitral valve is closer to the left atrium, or is the left atrium that opens, the mitral valve opens from the left atrium, what do I do? So those are the things you need to question yourself before you study. So when you are studying, give me a minute. Okay, so with that in mind, with this whole information, anatomy, and the picture of the heart in mind, so the patient tells you, the doctor said I had a left ventricle problem, or I have myocardial infarction. Which part of my heart do you think could have been the problem? So you need to have that in mind. So one thing about this review is that, so one thing I believe so much and I advise strongly is that when you join me, one thing I want you to do is for you to be able to understand the content first. Understand the content first. Cut them in pieces. I have divided them in pieces. I divided them into the adult nursing, maternity nursing, pediatric nursing, and then psychiatric. And then I went into legal nursing and ethical nursing. I do have a video on ethical nursing. I'm going to send it out, and delegation and prioritization. So I'm going to send it out. So once you are answering the questions, you need to know the ideal thing. So if you know all the normal about the human body, head to toe, all the systems, renal system, if you know how the urine flow, how blood gets to the glomerulus, and then it gets filtered, then when they tell you there's a problem, there's nephritis, inflammation of the renal tubules, you can understand that there will be congestion somewhere, and you can know that there's accumulation of fluid. So if you don't understand this content and you keep answering questions, you get overwhelmed, you get too excited, especially when you answer and you get 20 over 20, or you answer the questions and you get 15 over 19. You would think you are the champion because I'm doing well in answering questions. But why can't I just pass this test? Why do I keep going and failing and coming back? So when that happens, you would call yourself a champion, but you will not know why you keep failing because you are not tackling it right. So I really want you guys to sit back, think twice, design up a study plan. I do have a study plan. If you want to follow that, that's fine. But if you want to design up your own study plan based on your schedule, you put everything together. I'm not question answering crazy, because if you don't understand your basics and you sit on that exams, the people that said the questions are not stupid. So if you are coming to read and understand how to eliminate questions, only how to answer questions, it's not about you going to the floor to answer patient questions based on who you can select. It's answering or dealing with patients based on who is critical and who need care right now. So that's one thing I'm going to tell you to keep it in mind, that the NCLEX people or the nurses that set the questions are nurses and they are not stupid. They know where to get you. So they intentionally frame it. The other day I used a scenario of a patient I had. I said, I had this patient, I walk into the floor. The patient just came in complaining that I've been having a cyst. I've been having a boil on my sacrum for 3 days now. Today I wake up, the pain is too much, I cannot endure. I have a history of diabetes. It's under control. I took my insulin this morning. So the assessment, all the vitals were stable. Then we had a DNC, or incision and drainage, not DNC, incision and drainage. So they had to do incision and drainage of the wound. After incision and drainage of the wound, then the nurse go back. I went back to check the vital signs, in like 30 more minutes, just to reassess. And now I see the vital signs have changed. The heart rate went up. It was normal before, now it went up. And then the blood pressure was normal before, it dropped. So heart rate is going up, blood pressure is coming down. Patient is tachy. So tachy, heart rate went up, blood pressure is coming down. We just had incision and drainage. The patient lost fluid. But remember, it was a boil. It was a cyst that they did incision and drainage. So in this, and the sugar, the finger stick was just still a little elevated. But remember, the problem was not finger stick. So at that stage, this is what NCLEX will ask you. So when you went back to recheck this patient vital signs, you saw that they present to you the vital signs, and they want you to tell them which one is abnormal or what you think is going on after they had the incision and the drainage. So after the incision and the drainage, I remember Clementina had talked about the patient having fluid loss. That was fluid loss. It was okay, but if it's a ball on the back, it's not enough to drain the patient to become hypovolumious. It's sepsis you want to think about. The patient could have an infection. So if you understand that this vital signs, heart rate going up, blood pressure coming down, is a sign of sepsis. So if it's a sign of sepsis, under sepsis on the NCLEX, what am I going to do? So you know that sepsis will demand that you call the provider. It will demand that you take cultures, you draw blood cultures, and after drawing blood cultures before you give the first antibiotic. So you need to have all this in mind, and you need to know how to connect them. NCLEX is not taking you as an expert nurse. They're not taking you as a nurse with too much experience before you sit for that exams. So you need to really get the point of NCLEX right before you can pass it. So don't, and another thing is the worst part of it is giving up. When you fail, you go back and you fail. The worst part of it is giving up. That's one thing I don't even want to encourage people. Sometimes you feel like, let me just let this be, because after all, I'm too tired to do this. But listen, the option is not for you to give up. So Beverly, Gertrude, and Amelia, I will get back to this topic because I had not finished the heart blocks yet when I did the heart blocks. But for today, I'm going to jump straight. I just showed you the cardiovascular system. I didn't explain that. I'm going to come back to that topic one of the days. I'll just hit on it slowly for you people. But I also do have a video on how I explained it, if I remember recording that video. Today, we are going to talk about myocardial infarction. So the one you just saw is the anatomy of the heart. I like to talk about the anatomical component first before I go into the disease process. So when I'm talking about the disease process, you know what is the problem. So with the heart, as you saw the picture, we have the blood flow from the superior and inferior vena cava into the right atrium. And from the right atrium, it moves straight back to the left ventricle. I said I'm not going to explain it, but I feel like I'm cheating you guys. Okay, so we have blood from your whole body, head to toe, being drained into the superior and inferior vena cava. They are the blue markings. So blood is draining from your head, from your toe, peripheral come from down, this one upper come from up. They go into this cavity. So this hollow thing is called the right atrium here. And then we have the tricuspid valve that opens up to allow the blood to come in here. And that blood go in straight through the aortic valve. So this one is the aortic valve, pulmonic valve. So this one is a pulmonic valve that opens. The pulmonic valve goes straight to the lungs. So this one goes straight to your lungs. I cannot write lungs with this one. I'm trying. So this one will take the blood that is deoxygenated because your whole body have consumed all the blood. Now it goes back through this line straight to the lungs. Now the lungs supply it with oxygen. This is the pulmonary artery that takes that blood inside, and the blood supply, and the lungs will supply with the oxygen, and now it comes back. Where's my mouth? So now it comes back through the pulmonary vein into the left atrium. So the blood is now coming. So blood that is coming in from here is from the lungs. So you can see the relationship between the heart and the lungs. I had discussed respiratory system with the other team, so they know the link. So the link between the heart and the lungs is the pulmonary artery and the pulmonary vein. And that starts with the pulmonary valve. So the pulmonary valve is the one that will open for the blood to go to the lungs. So they get this oxygen and it comes back to pulmonary vein. When it comes to pulmonary vein, it's now oxygenated. So it now looks red. So it goes into the left atrium, from left atrium to the mitral valve, and from left atrium to the mitral valve here. And from the mitral valve, it goes through this one, this aortic valve. So the aortic valve is here, and that one goes to the aorta. And the left ventricle, which has a thicker muscle, push the blood all the way through the aorta, and this one go to your whole body again, from head to toe. You get all the blood supply. So I'm going to limit that explanation here. When it comes to EKG strips and EKG readings, this is the electrical component of the heart. We do have the sinus node, which start from the atrium as well, and they supply the heart with electrical activities. So if you have myocardial infarction means there's death of cardiac muscle. So this one's in here is the cardiac muscle. So when there's death of this cardiac muscle, this is the left ventricle and this is the right ventricle. The right ventricle looks bigger and the left ventricle does look a little smaller because it's been pushed by the lungs to each side. But the muscle on the left ventricle is heavier and thicker because the left ventricle does a lot of pushing. It pushes the blood all the way to your whole body. So it has to do a lot of work. It needs so much strength. So it has extra muscle than the right ventricle. Right ventricle only receives the blood from the atrium, and the pushing it does is pushing it to the lungs. So it doesn't push so much. Now, mind you, these times I'm using this pushing, the left and the right ventricle. When we come to disease conditions where the heart is diseased, you see that they are not able to push well. And then you see that blood is getting stuck. This is why you have congestive heart failure and all those things. So I'm jumping straight to my cardiac infarction after I have given you that little chichi. So myocardial infarction, I spoke about angina the last time. Today I'm talking about myocardial infarction, and this one occurs when myocardial tissue is abruptly and severely deprived of oxygen. So like you just saw that if there is no enough oxygen and there's not ischemia, they start dying and it leads to necrosis of the tissue due to lack of blood flow. You understand? So the infarction does not occur instantly, but it evolves over several hours. I think I spoke about this myocardial infarction the last time. Gertrude, you remember? I think I did. But anyway, so myocardial infarction, the heart tissue and the heart muscle is dead because it's being deprived of oxygen for one or two reasons. The oxygen supply is not enough. Remember, I told you about the oxygen supply to the blood, to the heart. The oxygen starts from the lungs, from the pulmonary vein back into the heart. So if it's deprived, and after 48 hours of infarction, it turns gray, yellow streaks develop as neutrophils invade the tissue. So neutrophils are a form of white blood cells, and they invade the heart tissues. The moment there's death, the moment there's oxygen deprivation, everybody starts setting in. It gives an opportunistic problem to set in. So we have within 48 hours, I said that, by 8 to 10 days after infarction, granulation tissues start forming. So this is into the typical anatomy of it. Even though we are not in a school setting, we are just doing a review. So we are revising this one. We are just passing through it. So if you want to understand it, you can get a message book. But granulation tissues start forming, and this is 8 to 10 days after infarction when granulation tissues start forming. Over 2 to 3 months, the necrotic area develops into a scar, and scar tissues permanently changes the size and shape of the ventricle. So myocardial infarction has to do with the ventricle. So when you look at the EKG reading, that was why I was telling the other group the last time, the EKG reading, the problem will be the ventricular problem that will cause on the EKG strip. I will go over it. So it's not all clients who experience myocardial infarction symptoms. They all don't get symptoms. Sometimes you are asymptomatic. That's why the moment the patient come in and you realize it's MI, you see the rash on it. The American Heart Association has a 3-hour window period. The moment the patient walk in and you identify ST elevation on the EKG, 3-hour window period, you have to get that patient to the cath lab for further care to see if it's reversible. So it's usually unnoticed until it is worse. So women may experience a typical discomfort or shortness of breath or fatigue and often present with ST, non-ST elevation myocardial infarction. That's for women. Or a T-wave inversion. This is for women. So if you're a woman, this is what they will see on your EKG strip. There will be no ST elevation, and there will be a T-wave inversion. So instead of having the T-wave peak go this way, it goes in like this. It rather comes down and go this way. So an older client may experience shortness of breath, pulmonary edema, dizziness, altered mental status. So the ST elevation for women that is non-ST, men will have ST elevation. So with men, the EKG will be ST elevation. NCLEX is not really concerned about either it's a man or a woman, but NCLEX will be concerned about the fact that there is an ST elevation in MI. They like to use that one. They may not describe to you if the patient is a man or a woman. They'll just tell you a patient presents to you. Now, mind you, NCLEX give you only 4 patients. So in every question, the patients that you have to answer questions are the answer options. Each of them is a different patient presenting with a different problem. So you should be able to understand who is critical because you understand the background of the patient's illness. So if they talk about MI, they talk about asthma, they talk about abdominal pain, or they talk about gastritis, the 3 conditions, you understand that these are 3 different patients and you are the nurse. You have all the time in the world to decide who is more critical. That's what NCLEX wants you to know. They don't want you to know how to just eliminate. You are not going to the floor to select patients. You are going to the floor to care for patients who are actually in need. My thing is not moving. Okay, we have the location of MI. So obstruction of the artery. This one is the corona, is about the corona. LAD is one of the coronary arteries. And this one results in anterior wall or septal myocardia on both. So when you look at the right ventricle and the left ventricle, you saw that there's a line that is dividing them. That's the septal wall for the heart. The heart also has a septum. Just like the heart on our chest, we have the septum. So the heart has a septum, the septal area. So if the effect is on both sides, towards the left or the right the right ventricle, right and left ventricle, that's where there can be an obstruction. So if the blood supply, which is mostly the arteries that supply the heart walls, they carry the blood and they push it inside there. So if those ones get a blockage, if there's obstruction, that means there's not enough blood anymore. So if you were flowing freely and then I come to cut here, so if I cut here, there's no more blood. So this side of your body or this side of the heart tissue starts suffering, the necrosis. Now, obstruction of the circumflex artery results in posterior wall of the myocardial infarction or lateral wall. Then we have obstruction of the right coronary artery resulting in inferior wall of the myocardium. So when you look at the myocardium of the heart, this is supposed to be another image. The myocardium of the heart, we already know the heart muscles. We have the epicardium, myocardium, and endocardium. So the myocardial portion of the heart is what they are describing here. So there are arteries and there are veins and blood supply system into it. So if any of them is affected, but in general, NCLEX wants you to know the specifics for MI. So let's go to the specifics for the MI. So the locations usually doesn't matter for NCLEX here. I'm just telling you for you to have a note as part of your learning. you need to know that the MI can be in various locations. So if they describe any location, you are fine, but you need to know what is specific about the heart, cardiovascular system. I had done cardiovascular system assessment that you need to do that are specific. So I had mentioned it again that if you have a patient that is complaining of abdominal symptoms and they are talking about medications and they add a medication that seems to be aspirin, you have no business choosing cardiovascular medication or antiplatelets. So you need to get it right. Their system, when you divide the whole human body head to toe into groupings, and my problem is musculoskeletal, and then you are giving me clonidine. It doesn't make sense, but that's what NCLEX would do because they put the information from nowhere and they adjust it to look nice. So you are looking for the nice answer, or you are looking for one that seems right. You are not just sure because you don't know what musculoskeletal is. So or what is specific about the long bones and the short bones in the human body. So if you don't know and you don't get that one straight, you can go and answer an option that is talking about respiratory system management because you were taught about airway to always tackle that first. You would be wrong. Now we have the risk factors. So for the sake of review for NCLEX, we are talking about risk factors. So if they present to you that a patient came in and this patient has been a chain smoker for the last 4 years, and today the patient is complaining of chest pain, the patient is complaining of this, and when they did the blood work, the troponin was a little elevated. What is the initial management? That's NCLEX standard question I just asked. So the risk factors is atherosclerosis, elevated cholesterol, smoking, hypertension, diabetes, hypertension, obesity, physical inactivity, impaired glucose intolerance, and stress. So these are risk factors. These are factors that place a patient at risk for MI. Now we have the labs. This is where I remember that I've spoken about it. I'm not going to go into details. I'm only going to talk about the troponin and the CKMB. Those are the cardiac markers. So troponin is cardiac marker. There are 2 of them when we talk of MI. Myocardial infarction, NCLEX like to test to know if you know which of the labs that will be elevated. The one that will be elevated is troponin. Troponin will be elevated in 3 hours. So when the infarction starts, the cardiac muscles start dying now. Within 3 hours, when they draw my troponin, when they draw blood to do troponin, the troponin will be elevated. And the troponin is a general test for the heart muscle. It's checking for the whole heart function. CKMB is creatinine kinase myocardial, myocardial muscle or myocardial something. That has to do with the myocardium, the CKMB. It has to do with straight myocardium. I always have a difficulty mentioning the last word of it. So let me get it. I have it somewhere that, anyway, it's going to take our time, but it's CKMB is creatinine kinase myocardial something. Is it myocardium or myocardial? I don't want to use infarction. I don't know. I don't think it's infarction. I always have a challenge with that word, so I never put it in my head, actually. So but I want you to know that CKMB and troponin are the 2 most concerning labs when it comes to myocardial infarction and the NCLEX. So when they're asking you questions, they want you to know if you understand any of that. So let me explain to you the CKMB because I'm used to the abbreviation for that particular word. That's why I really cannot find it. I don't want to spend hours. I have it up there. So the CKMB, you said?
What did you say? CKMB are the most what?
It's more of the heart, the cardiac muscle, the myocardial muscle.
Okay.
So it's more, you are more concerned about it. But that one, it does not appear right away. It's all done through labs. So
okay.
Yes. So the troponin levels, you will get that one elevated in 3 hours if the patient has a heart attack. So that's why they will draw the blood and then they wait. And then if they cannot get a definitive ST elevation on the EKG does look a little weird. They are not sure. They are not very sure if it's MI. They let the patient wait and then they draw the patient blood in like 2-3 hours or in like 1 more hours from the time you presented the complaint to confirm that it's not the heart muscle, because troponin will start being elevated in 3 hours after you have the heart muscle death. So troponin elevation starts 3 hours after myocardial death. But the CKMB, that one, its peak elevation is 18 hours. So within 18 hours, by then the patient would have complained of chest pain, troponin would have been elevated, there will be cardiac muscle death setting in. So the troponin is creatinine kinase myocardial something. It's an isoenzyme. It's actually an isoenzyme. So its elevation peak is in 18 hours after the onset of chest pain. And it returns to normal within 48 to 47 hours. It returns to normal within 48 to 72 hours. So troponin levels also rise within 3 hours and it remains elevated for up to 7 to 10 days. So for all these days, when they keep checking the troponin every day, it's going to be elevated because you have MI. That's where they start putting up the workings. So I'm not going to go into detail. The next point I'm going to talk about, my mouse is misbehaving. I'm using my hand. So is the EKG. So the EKG will show either ST segment elevation, T wave inversion, or an abnormal Q wave, which may be present. Okay, so take note of those three. Troponin levels elevated in 3 hours, creatinine, CKMB, elevated in 18 hours, and it remains it comes back to normal in 48 to 72 hours. And then the next one is ST segment elevation and T wave inversion. So this one, they like to give you an EKG strip for a myocardial infarction patient, and they want to see if you are able to identify. So they're just showing you because there's ST elevation. They want you to be able to know if there's ST elevation. And if you see the ST elevation on the EKG, it tells you it's myocardial infarction. That's the only one that causes ST elevation on the EKG strip. Now we are going to I'm going to jump straight to diagnostic tests that will be done following myocardial infarction. You want to do, and then one thing you want to also take note, I didn't add that one, is the cardiac catheterization. It may be done urgently to determine the extent and the location of the extraction. So this one is the cardiac catheterization. That's why they send the patients to cath lab. They have to put a tube through the heart. Usually they pass through the femoral vein, and they go femoral artery, and they push a tube straight to the heart. And they want the tube to be able, when the tube gets there, it gets to where the blockage is, because they will do some kind of scan to see where the blockage is. So they are watching the tube go inside the patient's heart, and then they go straight to where the blockage is, which of the arteries that was closed. Then they use that tube. It has something like, it has a hole. So when they push it inside over the blocked portion, then they vacuum it, they suck it out, and then they pull it back out of the patient. So it's like a quick procedure that they do, but it's urgent. So they insert a long tube starting from your femoral vein down around your thigh, and it goes straight to your heart. They put a long plastic tube in there. That's the cath lab procedure. So those are the three things, the troponin, the CKMB, ST wave elevation when you talk of EKG and myocardia, and then you talk about the cath lab immediately. So the cath lab has to be done as soon as possible to identify the specific location of the infection, and then they do a surgical procedure to pull it out. So the exercise is for you to, if it's still in the acute stage, you teach the patient exercise intolerance or stress test to assess for electrocardiographic changes. So you have the patient do a stress test. So the stress test is to have them do some kind of exercise. If somebody has ever done any stress test, you know how that is done. We are not concerned about the procedure actually. We are just concerned about knowing that in the acute stage of myocardial infection, a diagnostic test can be a stress test. That's what NCLEX wants you to know. You are not a doctor to care about how the process is actually done. They have basic nursing care procedures that they will let you do when it comes to nursing, because those drag and drop questions, they have drag and drop questions on the NCLEX, and they want you to use basic nursing care procedure. They can just ask you how to collect a clear catch urine sample, and those, they put them as drag and drop. Okay, and let me just chip this one in. For the sake of COVID, I said it the last time, everybody have become messed up with the correct way to do temperature. Now everybody thinks temperature is the gun on the forehead. Even children knows it. So you have to take note of procedures like that. It's a nursing procedure, and police can ask you that to show them the correct procedure of taking temperature, and you should be able to. You don't need to be anyone you are in taking the NCLEX. You can be a CNA, LPN, RN, all of you, they can ask you that. So mind you about that procedure, because temperature.
So can you demonstrate that for us?
Demonstrate what?
How to take temperature, as cheap as that is. It can be somebody's down, you know.
So for you to take the temperature, it depends on the type of temperature. Okay. You know, we have different types. So the most reliable temperature, especially when they talk of children, is rectal.
Rectal, yeah.
Rectal temperature. So that's what you need to know. But NCLEX is going to give you the procedure, that the steps, and they ask you to drag them and drop them in and arrange them in order. So if it's oral temperature, you want to make sure the patients did not drink anything hot or did not drink any coffee, anything that will cause an abnormal readings. You understand? So in adults, they're going to ask for axillary temperature. So if it's axillary temperature, if the patient has taken something in the mouth and then you want to take, but remember rectal temperature is invasive. So mostly they'll prefer that one in children. So children will get most accurate reading in rectally. Adults, they can talk of the axilla. But if you have the rectal temp in adults, the question added rectal temp, go in for that one for an adult. It's mostly the best way to confirm sepsis or infectious processes. But besides the adult, axillary temperature is well accepted if you don't have rectal temperature, because it's a skin fold. So rectally, in here, you can bend here. Where you can get a skin fold to take temperature, you can do it. But the most accepted is here. So if the patient has eaten something hot, just finished drinking a cup of coffee, you want to do it rectally. So if you're doing it rectally, there's no need. I would say it's a clean procedure. It's not sterile. So there's no need go cleaning patient armpits. You understand? So you just put in the probe and then you instruct the patient to put the arm down and sit straight upright. You position the patient well, sit straight upright, and then you read it within 1 minute. So mostly you hear the beep, and then when it beeps, it's read, and then you record it. That's it. It's a simple procedure. They like to twist people's minds with it. That's why I'm talking about it. Let's not jump anyway. But just take note, because things that are developing, I did send you people some medications, some TV medications you need to take note of, because they like to catch people on that. They have medications that people's attention have gone on it on the society that people don't really think is a big deal, but it is for NCLEX. Now let's look at assessment findings for patient with myocardial infarction. There will be chest pain. So the patient will complain of crushing substernal chest pain. The patient will tell you the pain radiates to the jaw, to the back and the left arm, because the heart is more to the left arm. So the patient presents to you. The way I want you to look at NCLEX is that NCLEX is when the patient walk up to you in the hospital and tell you, I have chest pain and my pain starts from here and it moves down. I can feel it in this arm. This arm feels numb. Those daily communications we have with patients, that's what NCLEX used to send the questions. There's nothing special about it. It's just the complaint the patient presented. So the background behind it is you knowing what could be going on with the patient. And what could be going on with the patient will be given to you in the answer option. So those are the hints. So instead of them telling you it's myocardial infarction, the patient presented with a substernal chest pain, which radiates to the upper back and to the left arm. What will be your first intervention? So if you have the understanding of the key symptoms or the key complaint of myocardial infarction in your mind, you go straight to manage the patient as an MI patient. And that's a medical emergency. The moment they see the ST elevation in the EKG, they start the troponin, and then they go to cath lab. So they go to cath lab even before they come back to check for the CKMB the next day. But the CKMB is the most thing, it evaluates the cardiac muscle. So just take note of the complaint. It's going to be substernal chest pain radiating to the jaw, to the upper back and left arm, and the pain will last 30 minutes. It will last 30 minutes. Yeah. So if pain is unrelieved by rest or in 30 minutes, it is unrelieved by opiates. So when the patient complains like that, the pain, they will say the pain may occur primarily early in the morning. So usually patients say, I just wake up this morning and it's been 2 hours now. That pain is just there, it's staying. So they will, first of all, you want to give nitroglycerin. So the order will be nitro or opiates. So you give nitro, and we know that nitro is given every 5 minutes for 3 times. After the 3rd dose, they have to look for another intervention. You can't keep pushing nitro. So nitro is given every 5 minutes for 3 times, and you, the nurse, giving nitro on the NCLEX, when they ask you, you are not supposed to touch the nitroglycerin. You have to pick it up with something, because when you pick it, it has a fainting sensation. You can feel faint. You can faint it. I actually tried it one time because I have been hearing it and I wanted to have a real feel of what it is. So I checked my blood pressure before I went to touch it. I opened the nitro medication. It comes in a small pill container. I opened it and I poured it on my arm. I just touched it. I poured it up. I just put 1 pill on my palm. So when I used my finger to, my hand, my 2 fingers to put it like this, it was like somebody dragged all the blood out of my body. I got dizzy at once, one time. Yeah, so I'm telling you from real life experience. I told my colleague I did it as an experiment because I knew I was in the care facility. I didn't want to die, but I checked my pressure. I knew my pressure was okay, but I wanted to see how the feeling is so that I can talk about it. I say you are crazy. So nitro will be given first. So the patient complains of chest pain and substernal radiating upper back and left arm. You give the patient nitro first, 3 doses every 5 minutes apart, and the pain lasts for 30 minutes. Or yes, if the pain lasts for 30 minutes, then nausea, there'll be vomiting, diaphoresis, and dyspnea. So after nitro, the pain will not be relieved. So that means something else is going on. So these ones are other symptoms you want to note. But like I always tell my students, besides these symptoms, note that these are other symptoms you can have with every cardiac problem. So you want to take the specifics of the radiations. So for every patient with a feeling of chest pain, it can be coronary artery disease. It can be mitral valve problem. Anything that has to do with heart or anything that has to do with the heart can present with chest pain and upper back pain. So those are common symptoms you want to take note of. Signs of impending doom. When you have a chest pain that is not being relieved, you feel you are dying, you have tried everything. I don't know who has ever felt this, but sometimes you have some pain that you just feel like this pain, I don't know how I'm going to get it relieved. It's a sign of impending doom, and it will cause anxiety. That's why NCLEX assign you with one patient. You have to stay with the patient to help sustain the patient. Anxiety is a big deal. So you don't leave the patient. NCLEX gives you one patient, you have all the time. Don't say, I have to attend to patient number B. If that patient is the one that needs critical care now, you stay with the patient. So you obtain prescription. This is nursing management. This is what NCLEX is quizzing you mostly about. Your nursing intervention is what you, the nurse, would do. So you obtain a prescription, a description of the chest pain. So the patient presents to you and presents to you these signs above. The first thing you want to ask is more about the pain. Does the pain come and go? You administer the pain medication, morphine, nitro, as it is prescribed. So the first thing you want to do is assessment. So remember your nursing, what's the name? Your nursing process. Remember your nursing process. That assessment is always number one. So the patient comes to you and say chest pain is not enough for you. You need more information to be able to come to terms. So if you need more information, you don't understand that my cardiac infarction comes with all these things. How do you ask the patient, does the pain move? And if the patient tells you the pain that it moved to my right hand side, it doesn't move to my left hand side. If the pain radiates down to my stomach, so you are concerned, what are the organs closer after the heart? What are the organs down the stomach? So those are the things that you want to know how the internal organs are all related. So the pain doesn't go up, it doesn't radiate to the upper back, it radiates to lower back. And I have pain to my left hand side, abdominal side, lower abdomen, my flank area. So note symptoms, but when the patient say upper to the left arm, you know the location of the heart. You know what my cardiac infarction will present. NCLEX wants you to have that information on your fingertips. So for you to pass the NCLEX, learn how to study. You are not just studying because you know how to eliminate answers, because the people that are going to ask the questions, they are not going to base on elimination. They are going to base on realities, and then they ask you. So the nursing intervention is what you, the nurse, would do. So following an episode, an EKG, monitor lab values, all those things, bed rest, which is semi-fireless position, is what you, the nurse, would do. I will send you all these documents. I think I already did. I sent it to Sam this week. So the interventions following acute episode, you maintain bed rest as prescribed, provide range of motion exercise. You don't want the patient to be stuck in bed as well. So you want to maintain them with bed exercise. So lab values, EKG, BP monitoring, you want to check all that. So that's your nursing intervention. So now let's go to this one. Heart failure.
Heart failure.
Any question?
No, I don't have any.
Any question before I move to heart failure?
I don't have any.
Mm-hmm. Can I go to heart failure?
Yes, go ahead.
So heart failure is the inability of the heart to maintain adequate cardiac output to meet. It's the inability of the heart to maintain adequate cardiac output to meet the metabolic needs of the body because of impaired pumping ability. So remember, I just explained the heart to you. So the inability of the heart to pump enough blood to be able to maintain the metabolic need of head to toe of the person. Your heart is failing. It cannot push blood out anymore. So this is all about heart failure. So that's it. Am I done with that?
Yeah, go ahead.
So we have diminished cardiac output. So anytime you hear of a patient having a heart failure, or the NCLEX will not mention to you that it's heart failure. They will describe symptoms of heart failure. They will describe symptoms of myocardial infarction, So the patient comes to you and tells you that the doctor told me I have low cardiac outputs. And this problem started since last year. Since then, they have put me on medication. I'm taking medication and medication. And today they present with another problem. So those are the things you want to take notice of. So there's diminished cardiac output results in adequate peripheral tissue perfusion. So peripheral tissues, those that are far away from the heart. So if there's diminished blood supply to the body, that means when the blood starts coming up, it's trying to get to my brain. Before it gets to my fingertips, what do you expect? I start having problem with my peripheral vascular system. So your hands, your legs that are far away from the heart, they start struggling because the blood is not being pushed enough. Those that are coming is moving slow because it's not enough to fill up every organ in the body. So the peripheral system will always almost suffer it. So there's congestion of the lungs and periphery may occur. The client can develop acute pulmonary edema. So pulmonary edema when there is stagnation of blood in the pulmonary system. So we know that in the heart, when I have shown you the picture, we have the pulmonary vein, and we have the pulmonary valve. They push the blood to the lungs. So when they push the blood to the lungs and the blood is coming back to the left ventricle, and the left ventricle is not able to send it all out, and it's getting stuck in there. Remember, more is coming from the atrium to fill it. It's a continuous pumping system. So since the atrium keeps pushing it to the lungs, it's getting stuck. So there will be clotting in the pulmonary system, the pulmonary vein, and the pulmonary artery that retains the blood. There will be clotting because there's stasis. So it becomes edematous because we are filled up with fluid and we are not able to release it because the heart is not pushing it out and we are trying to push more. So there's edema, congestion in there. Do we get it? Does it make sense?
Yes, yes.
Yeah. I like to have people respond. I want to know, make sure you are understanding me. If not, I'll be repeating the explanation and it's wasting our time. We have the types of heart failure. We have the acute heart failure, which occurs suddenly. And we have the chronic heart failure, which develops over time. However, a client with chronic heart failure can develop an acute episode. So we have the chronic and the acute. So the acute is when you are just walking around, you don't know you have a problem until all of a sudden you are struck dead. So most people die of heart attack, especially those that have unnoticed hypertension and they are walking around. They die mysteriously and nobody knows. That's why my good people will start saying witches. Africa, we believe in witchcraft. That's the traditional belief. Okay. So types of heart failure, we have the right ventricular failure, left ventricular failure. Those are the two types. So we have the right and the left ventricular failure. That's it. Okay. So because the two ventricles of the heart represent two separate pumping systems, it is possible for one. So mind you this, I'm going to jump this explanation and I'm going to explain it now. So we have the right ventricle and the left ventricle. The right ventricle and the left ventricle. The right ventricle pumps the blood to the lungs. The left ventricle pumps the blood to the whole body, to the aorta and then to the whole body. So because the two of them represent two separate pumping systems, right ventricle does not pump blood to the whole body. It pumps blood to the lungs and to the left ventricle. So when there's a problem with the right ventricle, that's right ventricular heart failure. When there's a problem with the left ventricle sending all the blood out, that's a problem with left ventricular heart failure. They both have different signs and symptoms they are going to present to you. So if you don't get these signs and symptoms right, they will present to you right heart failure on the NCLEX and you think it's left heart failure. So I'm going to go straight to the symptoms of each of the sites. I think I'm jumping too much. I'm not going to go there now. Okay, these are the assessment findings. Let me jump here now. So assessment findings, signs and symptoms, right and left-sided heart failure. Let me make sure I separated them right. They both have different symptoms. I think I didn't, hold on. Okay, so this one here, acute pulmonary edema is right-sided heart failure. And then this one is the left-sided heart failure. So starting from here, each of them have symptoms that they are going to present. When I was making the note, I just remember that I didn't separate them right. So with the right-sided heart failure, remember the pressure is going to be on the left ventricle because the blood stops at the left ventricle for the left ventricle to push. Now the left ventricle is not getting enough, and the right ventricle is pushing to the lungs. So there will be acute pulmonary edema. So remember, the pulmonary system is more related to the right ventricle because the pulmonic valve opened from the left ventricle to take the blood to the lungs, and the pulmonary artery, the pulmonary vein send the blood to the lungs. So all the problem is going to be within the heart for a right-sided problem. The one that goes to the entire body is with the left-sided. So the patient presents to you with severe dyspnea. They will have difficulty breathing, nasal flurry, use of accessory muscle in breathing. So they'll have difficulty breathing, and this is because there's pulmonary congestion. Remember, the lungs is involved with right ventricular problem. The lungs, the pulmonary system is involved. So the right-sided heart failure, they present with you shortness of breath, they use accessory muscles. If you're not careful, you think it's asthma. They are wheezing, they have crackles on auscultation, gargling respirations, they are breathing and you can hear sound. There's pressure in the lungs as well. From the right atrium to the lungs, there is pressure. And that is within that is just speculating. The blood is getting stuck. The deoxygenated blood that's supposed to go to the lungs for oxygen and move to left ventricle is having a problem. So it's getting stuck in there. So the patient can start coughing out bloody sputum. And it's still left, the right-sided heart failure. Now the left-sided heart failure is supposed to go to the whole body. The left ventricle is supposed to push it to the whole body. Now the left ventricle is not doing that. So there will be acute anxiety, apprehension, restlessness. You are just restless because your whole body is not getting enough. Your brain is being deprived, your peripheral, your fingers, your whole body is just restless because we are not getting enough blood supply. You can have a headache as well. There will be profuse sweating. You see the patient sweating. That's how much the whole body has been deprived of blood supply. Your intestines, everybody is not getting enough. Cold, clammy skin, and cyanosis. Now I put this red thing here as a signs of left ventricular failure are evident in the pulmonary system. Signs of right ventricular system are evident in systemic circulation. This looks like a switch. So the signs of left ventricular failure are evident. You will see it more because from the left ventricle back to the lungs, there is no movement. It's just so hard. The left ventricle is trying so hard to receive blood from the lungs through the mitral valve, but it's not coming back. The blood is not being released. So the left ventricle is doing too much work to send out nothing or to send out less instead of sending out too much. So that's the systemic. So all the systems are involved in right ventricular failure. It affects the systems of the heart. All the chambers of the heart are impacted because it's not getting enough. But in the left ventricle, when there's a problem, it goes back to the pulmonary system that is being impacted. So take note of these red chichis. Those are things that NCLEX like to dig more into. So.
Can I see, please?
Okay. So that brings us back to our assessment findings, signs and symptoms.
Excuse me, but so in summary, right-sided heart failure presents with pulmonary or respiratory symptoms, correct?
Yes, that's what, let me just figure this out, because I didn't separate them before. It looked like I did have a mix up there. Let me make sure the symptoms I presented here are on the right track. Let me see. The symptoms are all right, they are all correct. But I just want to be able to give you the correct one for the ventricles, the ventricle right and left. I don't want to mix them up. Okay, so you can just write that down. I'm gonna give you the signs and symptoms first, the assessment findings. When we go on break, I'll come back and then I'll give you the correct link for this, because I was supposed to label it the day I was making my lesson notes, but I think I was rushing. So the assessment findings is what I just finished discussing. So I'm not gonna go back to that. Yeah. So I think we are done with that. I'm not going to talk about all this forward failure, backward failure, and systolic failure, diastolic failure. That has to do with the blood pressures, and NCLEX is not really crazy about that. They're just crazy about you knowing the symptoms the patient is presenting, that is right or left. Because if the patient has a heart problem, the patient is presenting with wheezing, your initial judgment will end at asthma. If I'm not mistaken, you would think it's asthma, but it's now clear that it's not only asthma that has that. Now let's look at the nursing care following an acute episode. Field illness. You assist the client to identify the precipitating causes of the heart failure and methods of eliminating the risk factors. Remember the risk factor, we had a lot of problems, atherosclerosis, smoking, obesity, and all those things. So if the patient is obese and the patient is having all these problems, you want to teach them about weight loss and dieting things and exercise. You teach them lifestyle, encourage them to verbalize their lifestyle. Some of them are just eating anything, just doing whatever they want, and they have a sedentary lifestyle. So if the NCLEX present to you about a patient who has a sedentary lifestyle, who doesn't do nothing and just resting, and then they're presenting to you with shortness of breath and all those things, you want to suspect the complaint is substernal chest pain radiating to upper back and left arm. You want to be suspicious of heart attack. So you want to dig more into the pain assessment first. You rate the pain using a pain scale. Then you let the provider know, you get an order for nitro. If the nitro is not relieved in 30 minutes, or the patient tells you the pain started this morning, those are symptoms of MI, a heart failure, and you want to jump on it. So these are the advice, if side effects of medications or care, instruct client. So anytime NCLEX use the instruct client, is another way to tell you to teach. So instruct, direct, inform, and to teach. They use certain words to mean the same action you will do to the patient. So I did make a video today about delegation and assignments. And I clearly stated the role and things that the LPN is required to do, and things that the unlicensed assistive personnel are required to do. I'm going to put them on the YouTube, and I'm going to open it as a public one to have you guys view it. But I try to protect most of those videos. So if you happen not to be able to watch it, just let me know. I'll open it up and then I'll let you watch it. So these are all teachings you will do. These are your nursing care. So when you are studying your NCLEX book, try to get specific nursing care for certain problems NCLEX present, because that's what they want you to know. You are going to the floor to be a nurse. And I had mentioned it to some people before. Beverly, I don't know where you work. Gertrude, I don't know where you work, but I had seen it on the form that you filled. What's her name? Beverly, I also saw that. So since you seem to be working in a healthcare facilities, there is one thing I'm going to tell you with the NCLEX. It is difficult for people who have seen certain things being done in the hospital to blend to the world of NCLEX, because you have seen how it is done. And when you go to the NCLEX and they present to you with the questions and they tell you the patient coming, the sugar is 50, how will you manage it? Then you start talking about apple juice, where you have candy. They don't want you to jump that sugar to shoot up. They want you to go a process. NCLEX doesn't want you to start with juice. They want you to start with candy. So, but because you have been on the floor and you keep seeing them do these things, the patient come in and is hypo or is hyperglycemic, and then you start giving IV fluid to drink. You start giving them water to drink to bring their sugar down. That's what you see. You find it difficult to pass the exam because that's what you keep seeing. So when you get on the NCLEX, you are not thinking what the book wants, what the standard is for NCLEX. You are thinking, you see the question and you are like, okay, I've already seen this one. They will first of all do an EKG if the patient says chest pain. Then you go straight and pick EKG. EKG is not number one nursing function for you. Assessment is your main priority with chest pain, not to go ordering EKG. Remember, nurses don't even order. So in the world of NCLEX, you don't ever want to pick an option that talks about you, the nurse, or a patient complain of chest pain and the initial option is to go and order EKG. It's because you have seen that being done. So for those of you who work in the healthcare facility, you really need to be careful. If not, it's going to be very difficult to cross this world of NCLEX because you have gone a step ahead. You have seen certain things being done shortcuts. You have seen this STEMI, that when the patient comes and they suspect from EKG, they see myocardiac infarction, they start rushing the patient with nitro and they start giving it. So you don't care that the nurse is supposed, the initial action is to assess for the pain further, to know the location and the sizes. So if you don't take note of that, you'll be studying and studying books, you will understand all this content, but because you have seen it being done the other way around, those are standard for the organizations. I have it in that assignment video, that delegation assignment video. The organizations have a standard, and nursing also have a scope of practice. So the NCLEX is testing you based on the scope of practice. So if you're a nurse in California, you should have the same standard in mind like I have. That if a patient has chest pain, I assess it. Not my facility says I should be the nurse ordering the EKG. Another facility, you have to go and call the doctor to put the order in. So we have facility standard and we have the nursing standard. So the Nurse Practice Act is the one that controls the nursing standard, and you need to go by their principles and start going by the principles that you see in your hospitals or at your workplaces. So I don't know where you work at, but what you see, cross it off your mind. If you remember that tabula rasa for psychology, for nursing psychology, tabula rasa, when babies are born with a blank mind without anything in mind, I want you to clean your mind from all what you see. Ignore it. You didn't see it. Go into the book. Follow what NCLEX is telling you, because you'll be missing all the correct answers because you have seen it done the other way. It is correct, you would have done it, but that is not the first step. We have inflammatory disease of the heart, pericarditis, inflammation of the pericardium of the heart. It can be acute or chronic. I think we need to take a break, right? I need some water. Yeah, so 3 minutes time, we'll take a 15-minute break. Beverly, sometimes we usually cross our time. We are supposed to close at 8. Sometimes we get so interested and we do close a little late. So I don't know if you are working today, but it seems you you look all ready for the day. Okay, so we are talking about inflammation of the heart, the pericardium. It can be acute or chronic. So chronic pericarditis is a chronic inflammatory thickening of the pericardium constricts the heart, causing compression. So you know that anytime you see ditis or itis, I-T-I-S is inflammation. So it's inflammation of the pericardium of the heart. We have the chronic one, and the chronic one is inflammatory process that causes thickening. It becomes thick and it becomes constricted. So if it's inflamed, it becomes thick. You know that when you have something that is inflamed, especially if my lip is inflamed right now, it's going to look big and a little thicker than it is right now. So inflammation of the pericardium. So we have the pericardial sac become inflamed. They're just describing it. The heart failure or cardiac tamponade may result. So inflammation of the pericardium can lead to a heart failure. Assessment findings of what you will see is pain in the anterior chest. I have pain in my chest, anterior chest, that radiates to the left side of my neck. You remember the signs of heart failure too, right? And my cardiac infarction. It radiates to the side of the neck, to my shoulder, to the left shoulder, or back. You see, they are all having similar complaints. That has to do with cardiovascular. So when the patient presents, when NCLEX give you a question that the patient is talking about chest pain radiating to the upper organs or the upper part of your body, think cardiovascular problem. So your answer choices at this point, I'm reading and it's talking about the pain was radiating not to the lower abdominal side, and it's radiating to this side, to my neck, to my jaw, to my head. I'm thinking cardiovascular problem somewhere. So that would direct you to look for the answer options. The pain is worse when the patient assumes a supine position, and it may be relieved by leaning forward. So you lean forward, that means you try to put a little pressure on your chest, and it gives you a relief feeling. So the pain is being aggravated by, it's being graded and it's aggravated by breathing, particularly inspiration, coughing, and swallowing. So the patient tells you, when I'm swallowing food, I have more pain. When I'm coughing, I have more pain. Remember, cough is a symptom of respiratory system, but it is being manifested because the heart has a link with the respiratory system because of the blood pumping system, pulmonary circulation. That's the link they have. So patients can have chest problem and they add respiratory symptoms to it. You just need to identify the initial complaint that will come before the respiratory complaint comes in. So if it is a chest, if it's a chest pain that is more of respiratory, it's not going to present to you radiating to the next side. No, it's going to radiate to other organs that are more linked to that side. It's going to go down to the renal system because the renal system is connected there. So renal system, heart problem, and respiratory in the lungs, the three of them present similar problems. But let's go further, we'll see how it works. So there'll be fever, chills, malaise. Electrocardiogram will show ST elevation and inflammation. I jumped that side. I like to talk about nursing intervention because that's the one they'll use to frame the NCLEX question for you. So the nursing intervention is what you will do first. You will assess the pain, position the patient. That's what you do to relieve. Don't worry, don't be too crazy about giving medications because there's something a nurse can always do to help a patient than to give only medications. So it seems our time is up, but the nurse is also going to administer oxygen. So when the patient is having shortness of breath, you don't need an order for oxygen. You put the oxygen to the lowest. If the order is coming, it's going to come in a higher dose. You can put 2 liters per minute. That's the standard you want to always start the patient with. If the patient has COPD, you put it at 2 liters. And the most you can put it is 3 liters. And I did have a question that wanted you to calculate the FiO2, the fraction of oxygen percentage. I don't know if Clementina remember that, but I did have a question like that, the FiO2. One of the days, you can remind me, or one of the days if I remember, I'll just chip it into one of our lessons and I explain to you how they calculate the oxygen percentage. So if I'm getting 2 liters, 24% of oxygen, how many liters is that? If I'm getting 28% of oxygen, how many liters? So NCLEX will ask you questions under that and they'll use percentages. That's the FiO2. So we have our nursing management is to follow all these things and you are done. So when we come back, we are going to talk about myocarditis. We're talking about inflammatory process of the heart. We started with myocardial infarction. We talked about angina. We talked about heart failure. Now we are talking about inflammatory processes, problems of the heart. So we started with pericarditis. We are talking about myocarditis. When you know the symptoms of these diseases, you are done with it. You can go answering questions. And then when you take the questions talking about pericarditis, you compare it with the symptoms you have. That's how I want you to learn so that you'll be successful. Can we take a 15-minute break?
Okay.
Any questions?
Sure.
I've been talking for a while. Any question?
No, I don't have any questions.
When we return from the break, I will ask.
Okay, thank you so much. So I'll see you 45.
Okay.
Oh no, it's almost 45, right? Okay, 48, we'll come back.
All right.
Yeah.
Okay.
Okay, so 48, we'll be back. Thank you.
You're welcome.
Mhm. Okay, we are back. Beverly, any question, any concern? Are you understanding the lecture? Is it making sense to you? I can't hear you. You are muted.
Yeah. I really need a book to go over this. I really need to read it.
I do send the materials when I finish the topic. I send it out to you.
Yes, I would have to go over it.
I don't like to send everything in bulk because people get everything in bulk and they relax.
No,
so
no.
when you get it, you understand it. Then next week I go over another topic, I send it to you. And then you have the week to go over it.
Yes,
I don't want
the one that, okay, sorry.
You said?
What you are going over now, going through now, I need to read it again to get
Yes, that's what I said. I already sent it to the other group because I had almost finished it. So I will send it to you.
Okay.
Yeah, I will send it to you as an attachment. Yeah.
Okay.
So is everybody back? Can we start? Okay, so we are talking about myocarditis. Inflammation of the myocardium.
Okay.
Just straightforward. Inflammation of the myocardium. So it's as a result of pericarditis. It can be a systemic infection or an allergic response. The signs and symptoms are what you will find, assessment findings. So assessment findings is when you are gathering your data, you get the information from the patient, you do the temperature, you get a fever. Patient can tell you I have shortness of breath. You can see dyspnea, difficulty breathing. The heart rate can be elevated. Patient will say I have chest pain. There'll be pericardial friction rub, gallop rhythms. Those ones will be found on the EKG. And the mama sound is when you listen to the heart. When you listen to the patient's heart sound. When you hear it. So your nursing intervention, you assist the patient in a comfortable position. Now, let me tell you, I had told the other group about respiratory system and positioning. So when you are nursing patients with respiratory system and cardiovascular problems, most of the positions you want to note is Fowler's position. It can be semi-Fowler's or Fowler's. Those are the two positions you are much particular about. Don't put a patient with a chest pain in Trendelenburg position or reverse Trendelenburg or whatever. You want to have the heart rest so that it can expand to its maximum. When you put them down, then you're going to have the lower abdominal muscles or organs push more on it and put pressure on it. So most of respiratory and cardiac problems, you want to have the patient in a sitting up position. Fowlers, semi-fowlers, they are good. 30 degrees, if they start using the angles, 30 degrees, 45 degrees, 60, 65 is good positions to use. Okay. So you assist the patient in an upright position and leaning forward. So remember, the first condition we talked about was the pericarditis. They say you should have the patient sit up and lean forward. This one to sit and lean forward, that is when there are inflammatory problems in the heart. So the advisable one is to have them lean forward to put some little constraint to help with the breathing. So you administer oxygen.
I sent you a message on the group chat.
Okay, I'll catch it up.
On Zoom, not on the phone, on Zoom.
I know. Yeah, so I'll get it. So these are the nursing interventions, and that's what NCLEX care much about, because you are going to be a nurse, what you will nurse the patient for. So your nursing assessment will be fever, anorexia, weight loss, fatigue. So the patient will tell you, I've been losing weight and I have this dull pain. It's not like a sharp pain, it's just a little dull, but I have this chest discomfort and I think I lost 5 pounds in the last 1 month. And so you're going to see all those things and it tells you. Now your nursing intervention is to provide adequate rest. You want to make sure they have enough rest. Oh, Clementina, your message didn't come. So you want to make sure they have enough rest. You monitor for the signs of heart failure. Anything that will cause an inflammatory process of the heart can cause heart failure. So that's the next thing you want to be. Oh, okay, Clementina, I see that. Oh yeah, I told you I was gonna get you that. So I have that. You might have to write it down, the signs and symptoms of the right-sided and the left-sided heart failure. I'm gonna give it to you in specifics now. I had captured them, but I think I rushed over them, so I didn't really study them well. So the right-sided heart failure, you have dependent edema. There will be edema in your legs and in your sacrum. Dependent edema is for right-sided heart failure. And you have jugular vein distension. Your jugular veins will be distended. The jugular veins are in the neck. Those are the signs the patient will present. There will be abdominal distension. Abdominal distension, right-sided heart failure. There will be hepatomegaly, inflammation of the liver. And then splenomegaly, your spleen will inflame. There will be anorexia, nausea, and vomiting. That's right-sided heart failure. You will gain a lot of weight. That's weight gain. Nocturnal diuresis. The patient will tell you, I urinate too much in the night. I'm not a diabetic. I don't have a family of diabetes, or I have a family, but I've never been diagnosed. You check the sugar will be normal. So nocturnal diuresis, urinating too much in the night. Swelling of the fingers and hands. So you see swelling in the peripherals. There'll be swelling. Increased blood pressure, fluid volume excess, or decrease from pump failure, or there'll be fluid volume excess. Now with the left-sided heart failure, the signs, it shows the sign of pulmonary congestion. There will be shortness of breath. So you see that there's no shortness of breath in the other one. In the right-sided, there's no shortness of breath. So there'll be shortness of breath in the left-sided heart failure because, Jennifer, stop it. There'll be shortness of breath in the left-sided heart failure because the heart is supposed to supply blood to the entire body. Now the blood, the oxygen, there's no oxygenated blood coming to the left ventricle. So there's short of breath. There's no enough oxygen. So you start struggling. There will be tachypnea. Tachypnea is difficulty breathing fast. crackles in the lungs. So when you listen to the lungs, you hear crackles because the blood is trying to move from the lungs into the left ventricle, but there's a problem, so it's not moving. So you're gonna hear crackles. And then you have dry hacking cough. So you are just coughing and coughing and coughing, dry cough. So if you have ever heard of a patient taking lisinopril that present to you and is just having cough, 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 that one too is called hacking cough. So that's the kind of cough. It's annoying cough, mostly in the night. So dry hacking cough, the patient will have that. So the patient will have paroxysmal nocturnal dyspnea. So in the night, the patient will have difficulty breathing at night. So when they lie down flat, they have a problem. When they get up to sit down, they sit down for a while, they have to change their position. So paroxysmal nocturnal dyspnea. Increased blood pressure, fluid volume excess. It does have the same for the end of them. So that's the signs and symptoms of the left-sided heart failure and the right-sided heart failure. Okay, Clementina. Can I go on now?
Thank you. Yes. Thank you very much.
Okay. So we're talking about the interventions, what you do for a patient with myocarditis, inflammation of the myocardium. So what you want to do is to monitor adequate rest. You help them, you provide adequate rest, and they will tell them to balance rest and activities. Monitor signs of heart failure, monitor for splenic emboli as evident by sudden abdominal pain that radiates. So mostly these things, you just want to do a lot of teachings. So when it comes to interventions with some of these conditions, it's a lot of teaching you are going to do. You are not the one doing it, especially if the patient is at home. I also want you guys to go and try to look for something to study about home management of patients that are sick. You want to know because they have some specifics about the home care nursing in the NCLEX. So they want to know if you are a visiting nurse and you get to the house. Mostly that one, they'll present to you with the dying patients that need morphine for pain control. So take note of those ones too. Some of those things, I'm just chipping them in. They are not actually part of what we are doing. Now we are going to talk about cardiac tamponade. Cardiac tamponade. Cardiac tamponade. So this one is a pericardial infusion that occurs when the space between the parietal and visceral layers of the pericardium fills with fluid. Cardiac tamponade. So when we hear the word tamponade, I want you to have a way of remembering it. So if you hear that one, it's just like fluid, filling of fluid inside a cavity. So just use that word fluid to remember it. So tamponade restricts ventricular filling. It stops the ventricle from being filled out. So they are talking about the pericardial effusion, which is the visceral layers of the pericardium. The fluid that surrounds the pericardium, it goes inside and fills inside the pericardium, and it's now causing problems. So when that happens, the client is at risk for cardiac tamponade. So, and this one is accumulation of fluid in the pericardial cavity. So the fluid that is supposed to be lining the pericardium, it then accumulates. Instead of lining the whole area of the viscera parietal, it goes and accumulates in one spot. So it's not supposed to be lying there. It will not be causing a lot of problems, and it can cause heart failure as well. So ventricular filling is reduced when there's pressure on that. So acute cardiac tamponade can occur when small volumes. Well, I'm going to jump on that side. Let's talk about the assessment findings. So far as you know what it is, accumulation of fluid, and the ventricle is involved, there will be problem with breathing as well. So assessment finding with pulsus paradoxus, increase central venous pressure. So there will be pressure in the veins that supply the blood to the pericardium. Jugular vein distension with clear lungs. So there will not be wheezing or any congestion in your lungs, to be clear. Distant muffled heart sounds. This one is where you listen with the stethoscope. I have talked about the types of heart sound, the S1, S2, S3, and S4. So where you listen, you put 1, 2, 3, you listen to the heart on the chest. Mostly respiratory, the lungs, you listen to it on the back side, on the ribs. So there will be decreased cardiac output and narrowing pulse. So your pulses too will be reduced. It will not pulse rate output. So the pulse will be reduced. The intervention is you need to be placed in a critical care unit, hemodynamic monitoring. So a patient like that needs to be placed in a critical care unit. Basically, I tell you all patients because it depends on what is going on. So the patient needs critical monitoring because there's accumulation of fluid in the wrong place of the heart. So you administer fluid, IV fluids as prescribed to manage the decreased output. So you administer IV fluids, you prepare the patient for chest X-ray or echocardiogram, prepare client for pericardiocentesis to withdraw pericardial fluid is prescribed. We know about paracentesis, the way they do abdominal tapping for liver problems. So this one, they pull the fluid out of the pericardium. So they insert a needle there and they pull that fluid out of the visceral parietal. So that's the procedure they will do. You are not crazy about this because that is not basically nursing. You just need to know what they will do for that patient. That's what NCLEX wants to see, so that when they are doing it as a nurse, you know how to assist. I have told you before on the NCLEX, if they tell you a patient is going for X-ray, the patient is going for CAT scan, the patient is going for magnetic resonance imagery, MRI. Those are procedures that you want to make sure the patient doesn't have any metal on them, any foreign object. If the patient has a pacemaker, it has to be documented, especially with MRI. It's used magnetic. It's used magnetic. So you don't want to put a patient there with a metal earrings. It's going to get stuck. You're going to cause a lot of problems. It can cause a lot of adverse effects on the procedure. So patients that are having metals on them and they are going for X-ray, echocardiography is just ultrasound of the heart. So this one is non-invasive. But those that are invasive, they use radiations and they use radiations and magnetic fields. You want to be more careful when you are doing the preparation. They have preparation for nurses. So that's the nursing intervention for those procedures I'm talking about. You want to ask, do you have dentures? Do you have metal? Do you have any foreign body in your body? Any foreign object in your body? Any pacemaker? Now for patients that have pacemaker on the NCLEX, their main concern will be that, especially the permanent pacemakers, I discussed that last week. Those with the permanent pacemakers, their education will be that you want them to be careful because they are not supposed to pass by metal detectors. NCLEX likes to ask that particular question. The patient will come to the store and is in the store doing shopping, and the patient is going out, but the patient had mentioned that he has a pacemaker and something like, they like to frame questions like that. Those people with permanent pacemaker, it doesn't distract their activities of daily living. They're supposed to live with it and move around to regulate their habits. So they just need to be careful of metal detectors, and they need to know symptoms of low battery. When the pacemaker battery is running low, they need to know all those symptoms. They start having faint sensation and all those tachycardic stuff. So they need to report back. I jump into pacemaker, I'm sorry. Now, valvular heart diseases. So when you hear the valvular, you want to know about the heart, the valves. I spoke about the mitral valve, tricuspid valve, and the aortic valve and pulmonic valve. There are 4 of them: mitral valve, tricuspid valve, pulmonic valve, and aortic valve. The heart that I showed you, the picture has 4 of them. So we have the valvular heart disease occurs when the heart valves cannot open fully, or the stenosis, or close completely, insufficient or regurgitation. So we know that the tricuspid valve is between the arteria, the left atrium, and the no, the right atrium and the left atrium, that's the tricuspid valve, it opens up. So where it cannot open up fully, or where it cannot open completely, there is the problem. Most often, I don't know if you have heard of patients telling you, I had a valve replacement, I have stents in place, I have valve this and that surgery. Now, one thing I had mentioned that I didn't mention today, I'm going to repeat it. NCLEX like cardiovascular a lot, because when you look at our system, when you look at where we live, America, or even everywhere, cardiovascular problems is the #1 killer. Mostly they will limit it to statistics, and they use ethical reasons. They will say African Americans have a greater chance of dying with cardiovascular problems. But listen, cardiovascular problems is so much that they like to dig into it. There's no way you go to the NCLEX and you won't have a question from cardiovascular system. They will dig into it because it's all over. Every day, all these patients are taking blood pressure medication. You see even younger ones, and they are all on blood pressure. And this is because human being has only one heart, and the heart is beating 24/7. That's the organ that never rests in your body. So the moment the heart stops beating, you are dead. So because the heart works 24/7 for all the years of your life, it is also growing old. And as you grow old, everything changes and the heart gets impacted. So when there are problems in your blood, it all bounces back to the heart. So the heart is a big organ that NCLEX will dig into it. So take note of conditions and where to identify them on the heart's cardiovascular system, and it will help you to be able to understand their symptoms and answer the questions correctly, which is our focus right now. So we have the mitral insufficiency regurgitation. That's the mitral valve. So valve is incompetent, preventing complete valve closure during systole. So when there's closing, is supposed to close well, but now there's no proper closing. So the valve prolapse is leaflet protrude to the left atrium during asystole. So this one, the mitral valve is between the right, the left and the right, the left atrium and the left ventricle. So when there's a prolapse of it, it opens backward. Then that's mitral valve prolapse. But where they start talking about mitral valve and they mention the symptoms, I want you to be able to picture the image of the heart and know where it's located. That alone will give you the symptoms. It tells you it's going to the left ventricular side. So symptoms related to that side is what you look out for. Aortic stenosis, valvular tissue thickened and narrows the valve opening, preventing blood flow from the left ventricle into the aorta. Aortic valve is the one that opens from the left ventricle. When the left ventricle is pushing that plenty blood to your whole body, it goes through the aortic valve into the aorta. So when there's a problem with that particular insufficiency, that means it's not doing its opening and closing well. All of them that has automatic work system that they all respond. Now we have the pulmonary valve disorders. There is the need for repair for procedure. So they have repair. That's what I just told you. They have so many procedures for them. Literally, you see patients talking about, I had valve this. I talked about that already. Percutaneous balloon vulvoplasty. A balloon catheter is passed from the femoral vein through the atrial septum to the mitral valve, or through the femoral artery to the aortic valve. So the pass is like, that was the same thing I described. I don't have a pen here. It's a long stick that they have a balloon. It's like, you know, when you take the urinary catheter, the Foley that they insert, there's a little balloon around it somewhere. That's the one they will push the water to go and inflate it to keep it in place. So they have the balloon sealed around the tube. So they use that tube to go through your femoral artery on your thigh. And that thigh, they use the monitoring system. They monitor the wire, go straight to your heart, and they push it straight to the particular valve that is affected. And when they push it in, they're trying to open more of it. They're trying to manually open it. Instead of having it open in and out on its own, they insert the balloon there to have it open so that it can allow blood to flow in and out and kickstart it. So that's the purpose for those kind of procedures. So that's the balloon vulvuloplasty. They put balloon into the valve to open it up. Now, mitral annuloplasty, I'm not going to talk about this because they don't really care much about it. The only thing I care for you is to understand the science, because NCLEX is not going to mention the topics. They are going to mention what you, the nurse, will do first. They are going to mention the signs and symptoms that a patient will present with these problems. I'm just telling you for you to know that they do procedures to have them replaced, but you only need to understand how to manage some of these patients. So you know the symptoms, that there will be dyspnea, there will be mitral regurgitation, there will be congestion in the heart, and that can lead to heart failure and all those things. So now you know that when the valves are affected, having blood flow from one chamber to the other is also a problem. So all the symptoms they'll present to you will be cardiovascular, and cardiovascular system will all have similar complaints that the patient will present. All you need to know is, what do I do? Positioning and breathing and patient education. So when you are learning for the NCLEX, make sure those that talk about patient education and patient questions, you try to tackle those topics very well, understand how to respond. You never give a vague response, or you never ignore the patient question. Even if it's stupid, you have to answer it. Now I put a little note here. I said thromboembolism. Embolism can be a problem following valve replacement with a mechanical prosthetic valve, and lifetime anticoagulant therapy is required. So patients that get the valve replacement surgeries, they tell you, I have an open heart surgery. I had a heart surgery last week. All those people, they do those procedures. It does look simple. It looks like just one day procedure. They go in and come out. But when they come out, there's a risk for thromboembolism. There can be an embolism, accumulation of a clot within that, because remember they put in something through the artery all the way to the heart. So they give them blood thinners. So those patients with heart problems that go for surgical procedures, take note of blood thinners. They use blood thinners. So when they're taking blood thinners, you know there are certain medications they shouldn't get on the NCLEX. So they'll tell you that the patient says, I take this medication. They're not going to tell you it's a blood thinner. They are going to mention, I take Plavix. So the patient is taking Plavix. What will be the next step by the nurse, or what will you educate the patient on? So the patient is going for valve or heart replacement, and the patient says, I take Plavix. So that's a question mark for you. You have to follow that up on that statement. So those are the things in place we want you to know. Vascular disorders, cardiomyopathy, right? Yeah. Cardiomyopathy is a subacute or chronic disorder of the heart muscle. Cardiomyopathy, we know about those myopathic conditions. That means wasting. The treatment is palliative, not curative. You cannot cure it. So that when we talk like what do I talk? Failure to thrive, that causes muscle wasting. You see the muscles are just wasting. A lot of conditions. So cardiomyopathy is a disorder. It can be subacute or chronic disorder of the heart muscle. That's muscle wasting of the heart. And the treatment is palliative. You can only give palliative. You cannot cure it. And with numerous lifestyle changes and a shortened lifespan. So the types and signs and symptoms and treatments are, what did I say? I think I missed the signs and symptoms for that one. I need to get that fixed. So I missed the signs and symptoms of the cardiomyopathy. So the cardiomyopathy, you see weight loss. The patient will present to you with weight loss, and it's not weight loss that will be so gradual. It's going to be like slow weight loss, because this is a chronic problem, and they will have fatigue. I easily get tired when I do any little activity. I get tired, and sometimes I feel some dull discomfort. It's not going to be a sharp chest pain. It's going to be dull discomfort in the chest. Now let's look at vascular disorders. The venous thrombosis. Thrombus can be associated with an inflammatory process. So you sometimes, before I graduated from nursing a couple of years back, I really didn't know thrombosis, venous thrombosis could be related to the heart. I was so ignorant. I kept reading this thrombus formation process, blood clot formation, and I never knew it. deep vein thrombosis. I never knew it's related to the heart. I used to associate that to respiratory system. I really didn't understand the link between respiratory and cardiovascular. So we have the venous thrombosis. It's part of vascular disorders. So thrombosis associated with vein inflammation, phlebotrombosis, thrombus without vein inflammation. That's the phlebitis. That's vein inflammation associated with invasive procedures such as IV lines. So these are thrombophlebitis or thrombophlebitis, inflammation that associated with IV line placement. So you put an IV line, you come back and it's swollen, it end up become like sepsis or something bad. So that has to do with a thrombophlebitis, inflammation of veins. So deep vein thrombosis is a more serious than a superficial one. So that one is a little serious, it's deep vein. It's not like the phlebotrombosis or thrombophlebitis. This one is deep vein. So we have veins that are very deep, and it's those veins that are inflamed. So in that case, you avoid using the knee gauge or a pillow under your knees. You do not massage your extremities, and then you provide high or knee-high anti-embolism stockings. So this is the management. This is the care for this particular one. So you provide the patient with anti-embolic stockings. Mostly it's going to be in the veins of the extremities. That's what that one is. So when there's a blood clot, that stops there and it blocks the flow of blood. So the treatment for this one is to administer thrombolytics. They give thrombolytics, ATP or TPA. I remember there's a nurse, there's a nurse who did not know what TPA is. It's tissue plasminogen activator. Is an anti-embolic, antithrombolytic. So they give that to help declot the blood and then have blood to flow. Now we have risk factors for thrombus formation. Venous stasis from varicose veins. So people that have varicose veins, heart failure can cause that, hypercoagulability disorders, injury to the vein walls for IV injections, administration of vessel irritants, and then chemotherapy, isotonics, hypertonic solution. So we know that hypertonic solutions can cause corrosion. I think I have a video on that. I have a video on hypertonic solutions and all those IV fluid solutions. They can cause corrosion of the vein. They can corrode your veins. So if you take them for a long time, because they are hyper, that means the concentration gradient for those fluids is more than what your body should take. So if you take them for a prolonged period, it can corrode your veins, and then you can get venous stasis and then a serious problem. Now I move to ulcerative colitis, use of oral contraceptives, certain and malignancies. I don't want to talk about this. Fracture or other injuries of pelvis of lower. So these are still all the signs of the risk factors for the thrombus formation. So all of that are the risk factors for thrombus formation. So let me take this out. Now I'm going to talk about phlebitis, assessment findings for phlebitis. There will be red, warm, radiating up the vein, and extremity pain, swelling. So the extremity will be painful and swollen. So this one is phlebitis, when you have an IV line that is causing it. So you know about infectious or cellulitis and all those symptoms. This one has similar symptoms with that. That's inflammation of the vein. Nursing intervention is to apply warm compresses, moist soaks as prescribed to dilate the vein. So anybody that presents with you with a thrombus formation, your concern is to put warm compresses. So in that case, if a patient has a blunt trauma, you are worried that blood is going to flow from all parts of the body inside that cavity that is heated hard. So that's why you have the thrombus to form. There will be a formation. So if something hard hits me here, because something hard has hit, blood is running from other parts of my body and accumulates there. And then you have a bump up here. And that bump, if it's not taken care of, then it turns up that the tissues around that space start dying off. So the tissues start becoming necrotic, and then when they die off, they turn into liquid. It's another process of thrombus formation. They turn into liquid, and that's what comes out as pus. That's the dead tissues on that place. So when there is thrombosis or there's inflammation of the vein, blood is accumulated to that site. So what you want to do is to put warm compresses. So the warm compresses is providing heat to the site. And we know that when something is heated, it tends to tinge a little bit. So they say when it's heated there, blood supply increases because the veins are warm and they are actively working. So blood supply increases, and this helps reduce the swelling. That's why when you get hit hard, right now, the first thing people use is ice pack. Does it make sense? Or when you get a cut and it starts bleeding, it bleeds for the day. But tomorrow, around that site, you want to have a warm compress. For the first touch, you want to stop the bleeding. So with the bleeding, to have vasoconstriction, you use cold. But after vasoconstriction a day, the next day you want to use warm packs because you want to increase blood supply to the area. So the assessment findings will be calf or groin pain, tenderness, that's deep vein thrombophlebitis, pain to the calf. So the patient will tell you, we know the calf area, right, under the leg. So the patient will complain of pain there. So if the patient tells you, I have calf pain in my calf, and then the patient will have a positive Homan sign that may be noted. NCLEX can just mention it as a Homan sign. They can mention the sign direct to you. Then we have the false positive results that are common. And then this is not a reliable assessment measure. So the positive Homan sign may be noted. However, we can have a positive false result of that one, and it may not be a reliable measure for that. So we have positive Homan sign for deep vein thrombophlebitis, but don't be so crazy about it because it may not be a true one. We have positive one of it. Then we have the warm skin that is tender to touch. That's what you will find on your assessment. The patient's skin will be warm and tender to touch. Nursing intervention elevates bed rest. You provide bed rest as prescribed. So a patient presents with you with thrombophlebitis, mostly it will be in the veins, and usually those veins are around the legs, the lower extremities. Mostly it's around the lower extremities or the upper extremities for the vein swelling problems. But that has to do with cardiovascular. So when the blood supply has a problem, then you start having all those veins problems. So mostly because it's around the veins and all those things, you want to prescribe the patient to maintain bed rest. So you avoid using knee gauge or a pillow. I think those were the symptoms I put up there. Administer intermittent or continuous warm, moist compresses. I mentioned those things. That's your next intervention. Venous insufficiency. This prevents the formation of new clots. Monitor activated partial trauma. I'm going to jump all this. This one doesn't make sense. For NCLEX, I like to talk about what the nurse will do and knowing the symptoms. So what you will do is to instruct the client to wear elastic or compression during the day and evening if prescribed. So mostly patients with heart problems like that, with the veins problem, you want to tell them they are vascular disorders. You want to tell them to wear compression stockings day and night. So they should have compression stockings that are prescribed for them. And the compression stockings is to cause a constriction and have blood flow well. And prevent the thrombus formation. Then you instruct the client to avoid prolonged sitting or standing constrictive clothing or crossing the legs when sitting down. So if the patient likes to sit there and put the legs on the side, you tell them it's not the best, it's restricting blood flow. So these are advised teaching. Instructing means you are teaching. And this is what NCLEX set questions on, because they want your teaching ability to be strong. A nurse is a teacher. Your role to pass NCLEX, you have to know what to teach a patient for, because every condition they present to you, they want your ability to educate them. So the teaching is your job to do. And then, so this instructing is teaching that you'll be doing. So when you are studying your NCLEX book, please make sure you get familiar with the nursing care, nursing interventions, assessment findings and or the signs of symptoms. Those major things. When you know the disease problem, when you know what it is, then you need to know what you assess and find, or what the patient will tell you, and then you know what to do as a nurse. That will lead you to what to educate the patient about. Those are the three things I want you to put in your mind whilst you study for these exams. Number one is to know what the problem is. When you read the question, you try to identify what the problem is that they want you to tackle. For any of these 4 patients, you're tackling one of them. So if you know what you are going to tackle, you have to know the symptoms the patient is going to complain about, because NCLEX is going to give you only the symptoms. They don't want to tell you the problem. They want you to figure out either the problem, or they give you the name of the problem. They want you to figure out the symptoms. So they want you to go the opposite of everything. So you should know what to tell the patient. If I come to you, I trust that my life is in your hands and I'm safe. You understand my problem. That's why you are in that uniform, and you'll be able to teach me better. That's why the patients come to nurses. So the medications is wound care. So wound care, most of the thrombophlebitis stuff, you want to provide the patient with wound care stuff. Now, wound care is a responsibility for the LPNs. If you're an LPN, it's your job responsibility. So for the sake of Emilia, LPNs are the nursing assistants we have in Ghana. Here they tag them as LPNs. So the nursing assistants are the LPNs. They have they report to the RNs. So if you are a nursing assistant, you have the knowledge of aseptic techniques. So wound dressing is part of your responsibility. So questions that are about wound dressing, you are not going to be able to dodge it. You will get it on the NCLEX. So you teach them about wound dressing. That's why even though you are not there, there will be an RN on the floor, but if NCLEX is presenting you with the questions, you are the boss for that question. When you sit on that computer, every question they throw on you, don't think you are not the one to do, because it is you NCLEX is going to talk to. So the patient on the computer is your patient, and you are in charge. Whether LPN or RN, you are in charge. So your thinking capacity and your teaching ability to the patient is what will make you pass the NCLEX. You have to learn what to tell the patients. And I'm not saying go and start practicing now, because when you go and you start teaching the patient, I know some PCAs that teach too much because they know too much. If you do that, it will mess up with your studies. You want to focus right now and understand what the book is saying you teach. So don't go and practice this teaching right now on a patient. Practice it on the computer patients. Okay? Use the computer as a dummy and teach them. Now we have medications for that. We have tropical agents. We know if you have a wound, they try to give tropical agents, and they give some antibiotics to manage. Now, pain assessment. Assessment for the wound is to assess pain in the legs during dull aching after standing, a feeling of fullness in the legs, and ankle edema. Those are the things you assess the patient for. So if it's a vascular problem and it's the blood vessels that are having problem, it's part of cardiovascular system. Get it right. I used to think it's a respiratory problem. Vascular disorders is part of cardiovascular system. And the patient can have ankle pain, ankle edema, swelling. That's why you see a patient presenting with congestive heart failure with dependent edema. You see them come in and they have edema of their legs, and their legs are swollen, and they tell you, I have shortness of breath. Sometimes it may not be shortness of breath, especially initial onset. So a patient comes to you with first complaint, swelling in the legs, you want to think the heart has a problem. That's accumulation of fluid. I'm not going to talk about the sclerotherapy. It's a solution that they inject into the vein, and then they use that. It's just like when they inject a dye, when the patient take the contrast for them to be able to view it. It's a kind of treatment they use for treating vein problems. Now, I want to talk about the Trendelenburg test. This is a kind of test they use to position the patient in a supine position with the legs elevated with no Trendelenburg position. And this one is a test if varicosities are present, if the patient has inflammation of the varicose veins, they use that as a test to see. So the veins will feel from the proximal end. Veins normally feel from the distal end. So instead of feeling from the proximal end, it feels from the distal end. This is Trendelenburg test. That one thing I wanted to pick from this particular test is that they position the patient. It's a vascular disorder test. They want to see how the patient's vessels accumulate fluid in the lower extremity. So they position the patient in a Trendelenburg position so that they see how the legs are filling up. So if I have my hands like this for a long time, you know how the blood supply will look. So if I reverse it this way for a long time, blood comes down. And then the supply, the legs are already far from the heart and blood. So vein stripping, I don't want to talk about it, but let me just read it out. Varicose veins may be removed if they are larger than 4 millimeters in diameter. So this one is just removal of varicose veins. But listen, one thing I have noticed about NCLEX is that they don't like mentioning conditions that are common to you. If you realize, they like to mention conditions that are uncommon. Like instead of mentioning, let me see which condition has some botanical or some local name. If the condition, they like to mention conditions that are not familiar to you. It's just not familiar to you, but you have been reading it and over, but you don't know it has another name called this. I will get a question like that for you guys, because if they mention the patient has, okay, I'm going to look for a question that will frame it like that, and then it will mean a very common condition that you know about, and then I see how you figure it out. So now this one is arterial disorders, peripheral arterial disease, chronic disorder in which partial or total arteries are occluded. And this deprives the lower extremity of oxygen and nutrients. So the signs and symptoms will be intermittent claudication, pain in the muscle resulting from an inadequate blood supply. Let me talk about the notes and the next intervention. I think our time is fast spent. We may not be able to finish this as well, but I'm trying. So I said, because swelling in the extremities prevents blood flow, it prevents arterial blood flow. This one is about the arterial blood disorders. The client with peripheral arterial disease is instructed to elevate the feet at rest, to refrain from elevating them above the level of the heart. So you tell them to refrain to elevate their legs just down straight, but not above the heart level. Now, clients with venous problems, if they have vein problems, they have to elevate it above the heart level. But for arterial problems, they don't elevate them above their heart level. Okay? Do we get the elevation that I'm talking about? So in severe cases of peripheral arterial diseases, clients with edema may sleep with the affected limb hanging from the bed, or they may sit upright without leg elevation in a chair for their comfort. So you can just sit there and then you put your leg on another chair. But for those with the venous problems, they want you to pick it up. You can even use a pillow. So they like to talk about those things. So if it's a vein problem, you elevate it higher. If it's an arterial problem, you can dangle it down or you elevate it below the heart level. So there will be pain when you assess, you monitor extremity for color, motion, and sensation. So this one brings me to patient presenting to you with a question. We have instruct the client to walk to the point of claudication pain, stop and rest, and then walk a little further. So with the venous disorders, the request for bed rest, but arterial problems, mobility is encouraged. That's the two difference. So patient with vein problems, varicose veins, varicose that and that and that, arterial this, arterial problems, want them to move around. But if it's a vein problem, you encourage them to be at bed rest. So we have teachings that you, the nurse, have to do, and nurses are always teachers, and they have the procedures again. I'm not talking about the procedures, but let me just mention the peripheral artery bypass surgery. They do a surgical procedure. So they graft a material from your artery. So they cut one artery, the diseased one, they cut that one off, and then they pull the arteries to join each other. They also do that surgery in abdominal cases, laparoscopy. When they do the laparoscopic surgeries, they pull one to join the other. So when they cut one portion of the artery that is diseased, and then they try to pull it. So if the artery in my hand from here to here, this one is the one disease, they will cut here and throw that out, and then they pull from here and pull from here and join them together. They graft it to have it work right. So those are surgical procedures, and I'm not going to talk about the preoperative. We all know preoperative management of everything is to assess the patient, to get the baseline information. I mentioned it before, NCLEX will question you. Procedures that are mostly invasive, you need a written down consent. Procedures that are non-invasive, like you want to tell a patient to go for x-ray, you still need consent, but that one is verbal consent. So we have consent, types of consent. We have the written and the verbal. So the written has to be written and signed. Mostly it is done by providers, but you coming to do blood work for me, you have to take a verbal consent so that I can allow you to do it. But if I say don't do it, I don't want you to do it. NCLEX will tell you that. So that is it. Raynaud's disease is part of those vascular problems. I'm going to be off in 5 minutes. We have been talking for long and I see we are tired, but up to this point, up to the Beggar's disease, those are vascular problems. So I'm just going to finish Raynaud's disease and the Beggar's disease and we are done. I used to think they are all respiratory, you know. So we have the Raynaud's disease. Disease is a vasospasm of the arterioles and arteries of the upper and lower extremities. So Raynaud's disease, vasospasm of the upper extremity are the hands and the lower extremity, legs. So Raynaud's disease, they like to ask that question as well. Vasospasms causes constriction of the cutaneous vessels. It constricts them. Attacks occurs with exposure to cold or stress. Affects primarily fingers, toes, ears, and cheeks. So you see your fingers, I don't know who has seen that before, look very thick, mostly in a smoker's hands. If you know someone who smokes and they have been smoking for several years, now you see their hands, they get very thick and hardened. The blood supply, they look blue, black. You see their nails, discolored nails. So it affects mostly the fingernails, toes, ears, so the ears, and then the cheeks. So that's Raynaud's disease. Assessment find you see blanching of the skin, followed by cyanosis from vasoconstriction. So because there's reduction in blood supply to those areas, they become cyanosed. They look bluish, black discoloration like I just described. Swelling, they become numb, reddened tissues with vasospasm and it's relieved. There's numbness, tingling, swelling, and cold temperature at the affected part of the body. So you can feel that when you have been in the cold for a while, this I know you can understand. if you've been in the cold for a while, you realize that your fingers become like hardened. They just become like some heavy things that are difficult to deal with. Sometimes I'll be doing this, trying to get the blood supply to increase. So Raynaud's disease is when the area becomes black, it changes color because there's vessel constrictions to blood supply. So the blood vessels around them has been constricted and they don't get enough blood. Nursing intervention is to monitor the pulses, administer vasodilators. Something that would dilate those vessels is what you, the nurse, should be thinking about, but instruct the client regarding medication therapy. This one is a disease state. It's not like the water state that it happened only one time, okay? So it's not like one day thing, it's diseased. The person has it as a problem. So you instruct the client to wear warm clothing, socks, and gloves in cold weather. Advise them to avoid injuries to fingers and hands, Buerger's disease. That's, So this is what I was talking about. So when you go on the NCLEX, instead of NCLEX telling you it's Buerger's disease, they will mention thromboanginitis. The patient said they told me my diagnosis was thromboanginitis. They don't want to tell you it's Buerger's disease because the moment they mention Buerger's, that one is easy for you to remember. So they try to use some weird words that would just confuse you. They want to throw you off. That's what they do. So they are not stupid. They want to throw you off. We are not going to say Buerger's disease and you start knowing that it's a vascular problem. Let's mention thromboanginitis. But that is the other name. But for some questions that they just frame up the whole question, and at the end of the thing, you don't even understand where this condition is. All your days in school, you have never had a disease condition like this. Those are frame up. They frame up some questions that some words that doesn't exist. That's one thing I want to catch you people on the 75 questions, because I put something there that I want to catch you people on. So we have the Buerger's disease. It's an occlusive disease of the median and small arteries and veins. Occlusion of median and veins. The distal, upper, and lower limbs are affected most commonly. The assessment finding will be intermittent claudication. So ischemic pain occurring in the digits while at rest. So you'll be at rest and you still feel pain. So that's why some patients present with numbness, chronic numbness of my fingers. My fingers is always feeling numb for so many years. So that's where they'll present with you with that. Aching pain that is more severe at night. They have cool, numb, or tingling sensation the minute. So if you're not careful with some of these complaints, that's the only thing the patient will complain. The patient will not add chest pain. If you're not careful, you start running and jumping, thinking that it's heart disease or it's my cardiac infarction that you start jumping. The moment they mention numbness of my hands, they tell you this has been going on for 3 months and I've been having those numbness, but it doesn't have a link with the chest. I don't have a chest pain. I don't have headache. I don't feel dizzy. I'm not short of breath. I'm not this and that. It's not linked. It's a peripheral disease. It's a vascular. Vascular means blood supply problem. So that's where they refer them to neuro and all those things. So there will be diminished pulses or in the distal areas and all those things. So that brings us to the end of my lesson for the day. But take note, if you didn't get anything from this lesson, make sure the disease conditions I'm mentioning, you are just writing them down. You want to know diseases that fall under cardiovascular. That's all, period. And then you get the general assessment of cardiovascular system. I had discussed that in the first week, several weeks ago. So the general diseases of the cardiovascular system. Cardiovascular system is big. That's why on the NCLEX, you will see the EKG readings all by themselves. It's all part of cardiovascular. They are tackling it. So I see it's like we have been stuck on this for almost 2 or 3 weeks now, but we'll be done soon. See, we have like just 1 page, 2 more, and mind you, the rest of the things that I have down here after these aortic aneurysms, the rest of them that I have are management stuff. After that, I will come to hypertension, which is the #1 killer. lately. And then I'll come to the management things that you tell the patient. I have the pacemaker education, the home care instructions. So when we come back next week, so next week I had discussed with you guys if we could meet on Wednesday and Thursday instead of Tuesday or Monday. So next week we are going to meet Wednesday and Thursday. So when we come back, I will discuss these ones here, and then I will jump to cardiovascular medications. So the cardiovascular medications, I have them grouped up together, and that one will be able to manage these conditions. So I'm pretty sure when we come next week, I'll finish this one quick and I'll jump on the cardiovascular medication and we'll close our topic on cardiovascular system. Any questions?
No,
Do we have any question right now?
no, I don't.
Huh?
But I do not have any questions.
Okay.
But I would like you to send what you went over. I would like you to send a copy of it, so I could go by it over the weekend if you can.